I have to introduce myself? Okay, so today I'm talking about chronic post-surgical pain, and I kind of started thinking about this when I did my chronic pain term, and I realised that this happens a fair bit. Chronic pain, post-surgical pain, is actually one of the most common complications of surgery, and it's starting to become more accepted as an important outcome of surgery. So today I'm going to talk a little bit about the central nervous system changes, the pathophysiology of it. Going to look at some risk factors and whether if there's anything we can do to help reduce the incidence. So it's pain obviously after a surgical procedure. It's got to last for at least 2 months, and you need to exclude other causes of the pain, for example, infection. The grey area is where the pain, you need to exclude the pain continuing from the pre-existing pain problem, and because you can't always blame surgery, maybe it's just the natural progression of the pre-existing problem. So the importance of it is that it's important for the individual, it's important for us, for the medical system, and for the society as a whole. The burden of this problem is that for the individual, they're often on high doses of opioids and all the associated side effects with this. There's a restriction of their daily living, there's effects on their quality of life. For us, it's the fact that if the pain is not well controlled, they're coming into ED repeatedly. And obviously there's a burden on the society as a whole. The incidence really depends on the type of surgery, and it's quite amazing to look at the list of surgeries associated with this, because we all kind of know about amputation and phantom limb pain, but you can get phantom nipple pain as well, after a mastectomy. And there's all these other things like cholecystectomy that they've reported up to 50% incidence. And when you look at the numbers, it's quite surprising as well. For example, caesarean sections. We do so many caesarean sections, and it says about 12% there. So that's saying 1 in 10 women who have caesarean section are going to get this problem. There's a lot of variability in the studies, and this probably is related to the lack of clarity of the definition sometimes used, small sample sizes, there could be poor questionnaire responses, selection bias, different surgical techniques, etc. So it's kind of hard to know what the true incidence is, but even if you look at the minimum percentage there, it's a fair, when you consider the total number of surgeries, it's quite a large magnitude of people suffering this. This is another table just looking at the incidence for chronic severe pain. So that was the overall, before it was the overall thing. This is more severe pain, and if you look at the table, thoracotomy, 1 in 10 have severe pain, and caesarean section, you've got about 1 in 25. So it's fairly impressive numbers. So is the incidence really this high? Because it seems like it's pretty high. If it was this high, we probably would see more patients in the pain clinic, and it doesn't correlate so much. If they do a study looking at the outcome, primary outcome being chronic pain, the incidence reported is higher than if a study has a secondary outcome as chronic pain. So is it that the studies are overestimating this, or is it that patients just let you know when they about this only if they're asked? So I guess the worrying thing would be if there's people out there that have this problem but are not being adequately treated. So what's the mechanism? Well, it's pretty complex, and I don't think we fully understand it. there's different mechanisms responsible for different pain syndromes. For example, if you have an amputation, you can have phantom limb pain, or you can have stump pain. Surgery, in these models, surgery is really thought of as trauma. It's trauma under a, hygienic method. And this causes central nervous system changes after the injury, and it's really, the important factors are kind of biopsychosocial, so probably psychosocial factors are also important as well. But why some people develop chronic pain after surgery where others don't after even the same surgery, we don't really know. And we always come to central sensitization, which I'm sure everyone's heard of, and this is where there's repetitive nociceptive stimuli, and this causes changes in the dorsal horn activity. You get amplification of the sensory flow. This leads to persistent nervous system changes, and you get a phenomenon called wind-up, and clinically we see this as terms like hyperalgesia and allodynia. For example, in hyperalgesia, the pain stimuli causes more pain than you would actually expect. So this just shows an example, for example, in nerve injury, peripheral nerve injury, where there might be some increased sodium channel expression, and this leads to more sensitization of the primary afferents, and this leads to more spontaneous activity of that nerve, and this kind of bombards the dorsal horn. You're starting to see more glutamate release, more excitatory neurotransmitters, and you get reduced pain thresholds in the dorsal horn, and in response to a peripheral stimuli, the receptive field of the central nervous system expands a bit, so you get pain around the site of injury, and this kind of explains your symptoms of allodynia and hyperalgesia. Inflammation also does a similar thing by just the barrage of nociceptor activity, and the changes are really on all levels, so it's peripheral nerve, spinal cord, higher center pain pathways, even the sympathetic nervous system, so forth. So is it that it's nerve injury that's causing some of this chronic pain? Well, it's not so clear, because not all patients have neuropathic pain. And so there's no simple relationship between nerve injury during surgery and the development of chronic post-surgical pain. They've even randomized patients into where they've severed the nerve or preserved the nerve, and they found that there was no difference in the incidence of chronic pain. In fact, in one study for inguinal hernia repair, they deliberately did a neurectomy on the ilioinguinal nerve, and they found that the incidence of chronic post-surgical pain was less in those who had that ilioinguinal nerve severed. And many patients after mastectomy have some numbness, so they've got some nerve injury, but they don't necessarily have chronic pain. So the association isn't really clear there. I'm going to look at the risk factors divided into pre-op, intra-op and post-op. The things that are going to make it more likely in the pre-op setting for some kinds of surgery, for example, if the patient comes in with intense pre-op pain for hernia surgeries or thoracotomy, amputations, mastectomies, they're going to be more likely of getting this syndrome. But for total hip arthroplasty, it doesn't correlate. So it really depends on the type of surgery they're having. There's probably some genetic susceptibility and psychosocial factors like anxiety that I'm just going to talk about in the next few slides. Female gender and workers' compensation have also been associated with this. If you're older, you're actually less likely to get this. But you'll probably get aches and pains from everywhere else. Genetic susceptibility. So they've looked at patients after cardiac surgery. So they've got two cuts, one from where the venous harvest is taken, and they've noticed that for those patients who've got pain in both sides, that the actual incidence, they noted that incidence of pain in both sides concurrently was much higher than would be expected if the chances of developing pain at each side were independent. So there might be some kind of underlying something about those patients that causes this. And they've also seen it in hernia repairs where these patients have already got some history of chronic back pain and headache. Psychosocial factors, and there's actually not many studies looking at predictive psychosocial factors on chronic pain post-surgery, and it's not that clear. One study did look at anxiety, and they noted that anxiety was a risk factor for pain up to 30 days after breast surgery. It's a pretty difficult area, I think, to study. What does anxiety in the anaesthetic bay mean? It might be better to look at a patient's usual emotional reactions outside of the anaesthetic bay, because it's obviously a different scenario in the anaesthetic bay. And I guess this type of surgery influences that as well. If someone comes in for a hip replacement, they're probably pretty happy because they've passed a 2-year waiting list. But if someone comes in for a thoracotomy and for a lung cancer, then they're going to be really anxious about that. Intra-op risk factors more likely for longer operations, and probably related to it's going to be more complicated operations. Repeated surgery for hernia repair has been shown to be more likely risk factor. And the surgical approach is important as well. If they do a laparoscopic surgery for hernia and cholecystectomy, it's less likely to get this. So in terms of surgical factors, their size really doesn't matter. There's no simple correlation between size and this problem. The type of operation obviously matters, as we talked about, and how it's performed influences the incidence. For example, with mastectomy, if you have a mastectomy alone, in one study they said 31% had chronic pain. If you get a reconstruction with that, you're going up to about 53%, and if you have a breast reduction, 22%. So there's different types of surgery. Duration, one study talked about 3 hours and longer. In that study they showed a risk of getting chronic pain. The experience of the surgeon, well, it probably affects the morbidity and mortality, but there's no clear correlation to chronic pain. Looking at post-op factors, if they have radiotherapy or neurotoxic chemotherapy, this makes it more likely. Severe post-op pain, this comes up a fair bit for pain for hernia surgery or breast cancer, even after hip arthroplasty or caesarean sections. This is a significant predictor, and it's probably related to the whole central sensitization, just getting that repetitive nociceptive stimulation to the dorsal horn, setting up some changes in the central nervous system. And persistent post-op pain beyond the time that you would expect is another factor. Psychological factors like depression and anxiety, they seem to be related to, I think, acute pain, but there's no real correlation with chronic pain in terms of predicting chronic pain. I mean, obviously, a lot of people who have chronic pain will get depressed as an association there, but it's different with predicting. So the important thing is, I guess, for us is really, can we prevent this? The prevention is pretty important because once they get it, it's pretty hard to treat. So can we prevent hypersensitization? And preemptive analgesia, and most people have obviously heard about this. It's the idea of starting your analgesia before the surgery starts, before the trauma, and its aim is to be more effective than if you started later on after the whole wind-up or central sensitization has started. So timing is important with preemptive. It seems to be, for chronic pain anyway, there seems to be little benefit for preventing this by preemptive analgesia. The beneficial effects are certainly seen in the acute pain setting. So when they look at outcomes like pain intensity score in recovery or time to analgesia, or how much supplemental analgesic consumption there is, there's definitely seems to be an effect there. And epidural, in I think one study was showing that that is one of the most effective preemptive regional analgesias. So I think the focus now is moving on to protective and preventative regional analgesia. Protective analgesia is a technique that reduces measures of sensitization such as hyperalgesia, and preventative analgesia is where you get an effect from your treatment that lasts beyond the expected duration. So the timing is not so important now, whereas preemptive, it was about timing. This is not. So I think the focus is heading towards these two terms. And this is where your NMDA receptor antagonists come in. For example, ketamine. They do reduce, they've got a significant effect on preventive analgesia. It's level 1 evidence here. You do see effects in recovery when you do give ketamine, so the analgesic benefits last even up to recovery time. Also with thoracotomy, they've shown that epidural analgesia and also low-dose IV ketamine, and they're talking about 3 milligrams an hour, actually continued for about 3 days with the ketamine, reduces the severity of pain with thoracotomy, and also colonic surgery as well. They've studied it up to about 1 year, so which is interesting. It's a randomized controlled trial. Just put this table. This table's from the college publication, evidence-based. I found this interesting because they're saying that NSAIDs have actually preemptive effects. Now, I've kind of given my NSAID any time during the surgery, but I mean, if it's got preemptive effect, you really want to get it in there before they start cutting. And looking at preventive effects, gabapentin's a pretty hot topic, and it shows in a number of studies that it's got a positive effect. Local anesthetics, it's obviously good, and NMDA antagonists as well, ketamine, which I've already talked about, have preventative effects. This is about acute pain as well, so this kind of is not just about the chronic pain. So gabapentin, it's really being used a lot, obviously in the chronic pain setting, but the acute pain services are using it a fair bit as well, especially for, obviously good for neuropathic pain. Whether treating neuropathic pain in the post-op setting reduces the development of chronic neuropathic pain, we don't really know. I mean, you're going to treat it anyway. And gabapentin in the setting of preventing chronic pain, the evidence is pretty inconclusive, but it will help in the acute setting, I think, from some studies. Obvious strategies are basically effective management in the post-op pain setting in recovery. this is there's a lot of evidence that says that severe pain, post-op pain, is associated with chronic pain. Whether it's a causative link, we don't know, but you're obviously going to treat this, just to be nice to the patient. And the other obvious thing is that if you don't have surgery, then you're not going to get chronic post-surgical pain. So what I mean by public health measures is, for example, with amputations, you could better glucose control, stopping smoking, all those things may prevent actually having the surgery. So that's important, and it's really important to find out whether they actually need the surgery. There's cases of people pressuring and families pressuring the surgeon to do some surgery. I think one lady had like 50 abdominal operations just to find out why she was having this pain in her abdomen, and when they asked her, why you keep on having all these operations, she said she always thought the next one would help her. So obviously it's important to find out what the motivation is, and if you talk to the patient and say, you could get chronic pain from this surgery, they might think twice about having it. So I'm going to go through some summaries from the college guideline, just the main evidence for each of these syndromes. Post-amputation pain syndrome, it's pretty difficult to reduce the incidence. The evidence is really level 3 evidence. Looking at phantom limb pain prophylaxis, it showed that peri-op, so starting at pre-op, intra-op, post-op, epidural analgesia will reduce the incidence of severe pain, and you need to treat about 6 people to get this effect. Ketamine in this study showed the bolus dose followed by infusion prior to your skin incision and continued for about 72 hours. The incidence of severe pain was also reduced in this group. Thoracotomy pain syndrome, epidural analgesia, level 2 evidence as a randomized controlled trial, continued into the post-op period. At 6-month time, the patients are reporting less pain when you compare it to IV PCA. And if you add low-dose ketamine, IV ketamine, and the study I think was 3 milligrams per hour, to this you'll reduce the severity and the need for treatment of post-thoracotomy pain. They studied this up to 3 months. Post-mastectomy pain syndrome, in this randomized controlled trial, they put in a paravertebral block. They started pre-incision, and at 12 months there was less people complaining of chronic pain. Also, EMLA randomized controlled trial showing that helps, and they've also done it with a combination with gabapentin, and they said that helped as well. After a hernia, if you're less than 3 months of age, then you're not going to get any chronic pain. Level 4 evidence for this. It's obviously hard to make your patients young. Post-hysterectomy pain syndrome, peri-op gabapentin here, randomized controlled trial, also with a ropivacaine wound infusion. At 1 month, they had less pain. So a few studies with gabapentin, they've showed combinations of local anesthetic and gabapentin. I don't know if just pure gabapentin has been shown to help. And interestingly, spinal anesthesia compared to GA for seizures, it's level 4 evidence, but they're saying less chronic post-surgical pain. I won't go too much into the management. Obviously, everyone knows it's multidimensional. It's using the psychosocial biological model. I think the important thing is, in terms of education of patients, is when patients have pain, they think something's gone wrong with the surgery. So it's important to let them know that it's not always the case. Future developments, I think one interesting one is minocycline, which is a tetracycline antibiotic. And so it might be actually a cheap medication to use. It's anti-inflammatory properties, and they've actually given it before nerve injury, and they found that the hypersensitivity occurs less when they use this. And there's a few other things like sodium channel blockers, and so they're working on some other medications as well. So, in summary, there's not much research out there, but it is improving. There's more research going into this. It's a common, important problem, and I think there's some techniques that we can use to reduce the incidence. That's it.
Thanks, Peter. Charlie has a question.
With the ambular and mastectomy pain, when do you start putting it on, and where do you put it on, and how do you do it? Do you have to wait for the scar to heal, or do you just lodge it on straight afterwards?
I think if you're going to do it, you're going to do it before. I think they said before. Yeah, you need to do it before. I'm not sure how I'm actually studied that paper well, but I don't know. I just imagine it'd be around the side of the cut, but yeah.
Anybody else? Oh.
Did you read anything about the use of calcitonin in post-amputation pain?
In the acute treatment?
Yeah. Preventive pain, so post-amputation.
Yeah. I didn't read much about the acute side of things for post-amputation pain, but they did, from memory, I think it does help, but I don't know which scenario you use it for, but there is, in the book, in the college guidelines, there is definitely, saying there's a role for it and it helps. Yeah.
I'm doing a mastectomy list this afternoon. I can use up the supply of Adderall.
Yeah, well. I'll sweeten cold cream all over my breasts.
I'm with Amelia. Amelia's going to do that job for me.
Make sure there's someone else in the room with you.
Warm it in your hand first.
Thanks, Pedro.